So, very excited today to have another guest who works with Discern Health. Going to talk to us about data, interoperability, and the things that we should be doing to succeed and be doing great in value based care. Paulo, you want to talk a little bit about your background, your experience, and share with us what brought you here today to talk with us?
Yes, Shannon. So I'm Paulo Pinho. I'm a physician by background, board certified internal medicine and pediatrics, and practiced full time for about 15 years before going out into more physician executive roles. Initially spent some time in the employee health and the life insurance space before moving into the clinical data space. I previously worked in a company that was taking multi-source, multi-format clinical data and really creating a longitudinal interoperable document that really drove towards semantic interoperability, with the goal being to provide a data asset that was comprehensive to payers, to the federal government, state government, health information exchanges, et cetera. And I think one of the things that I've learned in my transition from clinical practice, which was a very one-on-one situation, is that I'm able to drive more population level initiatives and more population level care. I now work for a company called Discern Health. It's a relatively new company. We're small, but basically what we're doing is taking these clinical data assets, claims data, social data, and really using it to create predictive models that look at utilization patterns for individuals and how they access healthcare, but then also use it to predict elements of decline, clinical decline in the cognitive space, in the cardiovascular space, in the whether or not somebody's going to fall, et cetera. And so I think it's really showcasing the power of this multi-format, multi-source data that I've really used throughout at least the informatics part of my career.
So I heard so much great information there that I want to make sure that we go through and talk about each of the points in greater depth. But one of the things that I was hoping that you could start off with, because I think that there are a lot of listeners that there may be some that are more mature and understand value based care, but there are a lot, right, that maybe aren't as familiar. And so, could you talk a little bit more about why prediction, right? Why having those predictions would be important if one wanted to be successful in value based care?
Yeah. So I think that we practice in the United States as clinicians in a very reactive system, right? So it's a very sickness-based model of healthcare delivery. Somebody needs to become unwell before there's actually an intervention. And oftentimes what ends up happening is that there are key subtle points that maybe it's difficult for the untrained eye to look at and see that there's association between these points. Also, as we look at practitioners and providers of clinical care, the challenge is that we have a population of people that are aging. Their medical care is becoming more complex. It's becoming more personalized and nuanced. And we're still requiring that these providers see their patients in 7 minutes or less. And so sometimes all of that information in a synthesized fashion doesn't really bubble up at the point of care. And so there's really an opportunity with predictive analytics, predictive models to really use technology, really use data science as something that really surfaces to people in the healthcare ecosystem that are providing care for individuals, and really make it so that, hey, we're starting to see evidence of the fact that this person's risk of having an untoward event is increasing. There's a splay in the way their risk is gone, or it's exceeded a threshold where we're now really concerned that if we allow this to go unchecked, this is going to lead to an untoward outcome. If we look at the drivers of the predictive model, and I think one of the real important pieces around predictive models, around AI, is really explainability, right? Having the necessary inputs to show the user that, hey, these are the things that have increased this person's risk. These are addressable things that have increased this person's risk. Now let's go out and actually make an impact and actually address those things so that hopefully we avoid an event. Look at an event like falls, for example. It's not something that necessarily shows up on a risk management profile or something that shows up on a risk adjustment profile or something that shows up on a quality measure. But we know that if somebody falls, their acute morbidity goes up, their cost of care goes up, and their mortality goes up. So if we could look at the evidence of what medications is the person taking, how is the person utilizing healthcare leading up to it, what are some of the social factors? Has there been a recent death in their family? Are they challenged with caregiver support, et cetera? Now all of a sudden we're providing meaningful data inputs to a model that can say, hey, yeah, in the next year, this person has a sizable risk of falling. Let's intervene, right? Let's get them physical therapy. Let's do home visits. Let's do all the necessary things to ultimately deliver the best possible care and total person care for this individual.
I think those are great insights and would agree with you. I know I was looking at an article the other day that estimated the costs that were associated with hip fracture and how exorbitant that they could be. You talk about data and all this data and bringing it together. And we know that there are a lot of companies out there that are doing this work today. Maybe they're not taking in all of those pieces. And perhaps that's a differentiation with your company versus others. But maybe you could talk to us a little bit about how are you making sense of all that data? What's important? And I would love to, because I think it's important to call out that you're a physician as well, who understands all of this technology and the importance of data. And so would love to hear you overlay that as well as far as how you're being discriminate, what's important in when deciphering all of that data.
Yeah, those are great questions. And part of the rationale for my joining this company is that I think it was really putting the clinical aspect and the actionable clinical aspect front and center. I think there's a lot of data scientists, a lot of data science organizations that have crept up that are funded that really know how to understand the challenges of a lot of this data that comes in, but really piece it together for an output that really makes clinical sense really does require a level of clinical explainability. It puts the medical professional at the center of it because I think they understand the dynamic of the patient provider interaction. I think that we look at how providers document, it's not always the things that we would think that are really what drive documentation patterns in the United States are things like medical legal risk and protecting oneself and making sure that there's patient satisfaction and making sure that there's enough information to be able to bill and code appropriately. Those are sometimes the overarching driving factors of how providers document. Having a clinical team that understands how that documentation happens and what those drivers are is important to understand the data as it comes in. I think there's this tendency too of people to understand medicine as being very binary, yes or no. There's a whole lot of shades of gray in the middle. And sometimes really pulling in the different pieces to really come up with something that's a probabilistic score that showcases those shades of gray is very important, right? There's no absolutes in medicine. There's no nevers and no always. And so sometimes the evidence looks like this is the trend, but sometimes there is a piece of evidence that actually decreases the likelihood of that trend. So really piecing it together in a very Bayesian way in the way that providers normally think from a differential diagnosis standpoint and understanding that the output of these models is never an absolute. Rather, hey, here are the hierarchies of probabilities that exist for this particular individual. They have these features in labs, they have these features in radiology reports, they have these features from a billing and coding standpoint, but this is how they all interact. And this is the list of things that could be wrong with this individual with their relative weighted probabilities, really putting the data back in the hand of the clinician to now act on it. This is never going to be a substitute for a medical professional at any point of this equation, but really it's arming medical professional with a new tool in their black medical bag to ultimately augment their ability to diagnose and their ability to treat and their ability to action.
So I think, again, you bring up a really great point and possibility, if you will. So not replacing the provider, right? But freeing them up to do other types of work. Talk to me a little bit about what do you see happening in the space of that freedom? Is there anything, even your experience as the clinician, that you could share with others that if they were to adopt this or use this as part of the work that they're doing today, what would it open it up or allow them to do?
Yeah, that's a great question. And we know that a third to a half of medical providers' time is devoted to documentation. That's why none of us went to medical school. I mean, I didn't go to medical school to document. I went to medical school
Oh,
to
yeah.
have that human interaction with a human being that really needs that high touch connection. Oftentimes, events like the ones that we're predicting are catastrophic events to families. And not only do they have medical impact, but they have social impact and they have psychological impact, financial impact, et cetera. And so freeing up that time not to have to sift through data, but to have data presented in a way that's meaningful and actionable and really synthesizing and bringing it all together in one cohesive spot, I think really allows that provider to have a much more meaningful interaction with their patient. I think the other thing that's important is there's a lot of times where someone was seen in my office, and after I went back to document at the end of the day, after the visit was over and after they left, when I started piecing together things, there was no real time aspect to it. And I would often have to call people up and say, hey, there's one other thing that I thought about. And for that reason, I'd like to do A, B, and C and order this test, just to have that real time ability to impact into action and to set up what the next diagnostic or treatment journey is for that patient. It's time to impact. And I think not only are you improving the quality of that physician patient interaction or provider patient interaction, but you're also increasing the likelihood and compliance and adherence to medical treatment happens when a patient leaves with confidence that all stones have been turned and nothing's been left unturned. There's a very clear and concise path forward to get things diagnosed and treated. That's important from a patient standpoint. That's important from their family standpoint.
I love that you shared that moment of vulnerability about that patient leaving the office and then thinking about that one more thing and agree with you how important it is to be able to have that revelation in the office when the patient's there and just how much more it can provide. We've talked a lot about the physician experience and I can definitely see this being important to health plans too. I'm just curious as who do you see as being your ideal customer or ideal client? And then if you would take it a step further and talk a little bit about how someone would engage with you, how that person would engage you and where that process would start.
Yeah, great questions. Look, when it comes to healthcare, it really takes a village, right? You look at particularly an increasingly complex patient population, an increasing complex family dynamics, social factors that are clearly driving health outcomes, et cetera. There's really a lot of people that stand to be stakeholders in this. Certainly the federal government, state level governments, things like CMS and local Medicaid offices. So this is a really important thing in terms of right sizing cost and value. Obviously, the payer communities benefits from this. As we think about the ability to appropriately diagnose and phenotype and to have the assistive technologies, particularly for some of those diseases that aren't cut and dry, like we think about things in the cognitive decline space, for example, there's a lot of people that are diagnosed as having Alzheimer's disease when in fact they have another form of dementia, right? And knowing which patients truly have the characteristics that are in line with Alzheimer's dementia is really important when you start talking about these medications that are $1 million a year medications that are targeted medications for a specific type of dementia. Making sure you have the right patients included in that cohort is really important. So not only do the pharmacy aspects of health plans are they important, but also pharma itself is important. And so we're really, I think, really targeting provider and patient first and foremost. But these models really lend themselves to all different other players in the healthcare ecosystem. In terms of how to engage with us, so we have an online presence, obviously. Social media is one, and we've gotten some interest from social media. I do speak at conferences and have the opportunity to connect with people at those conferences. We have a website that actually you can connect with, and I can provide all that information to you or to anybody that's interested, and be more than glad to funnel them through the right pathway to get them connected with our solutions. And our models aren't limited. Like I said, we have about 30 different models, most of them based on morbidity and mortality of disease and the likelihood that we could provide the necessary data insights to identify which patients in a cohort or which individuals in a cohort are likely to progress in that direction, but then also have utilization patterns. What does it look like for somebody to see a specialist or have a really good relationship with primary care, et cetera? All of those things are really important to different stakeholders in this ecosystem. And again, those models, there's some people that only want one of our models, other people that are looking to buy bundles because they're all really impactful. There's a whole bunch of different ways to connect, and anybody that's interested in connecting, glad to talk to them.
Great. We'll be sure to provide the links and your information so that folks can get a hold of you. Tell me a little bit more about you talk about these predictive models that you're able to provide. How do you see physicians using those predictive models? Is it something that's happening concurrently as they're seeing patients? Is it something that they're employing prospectively, retrospectively? How are you seeing them integrated into the workflow as it exists today? Or does the workflow even have to change?
Yeah, I think that's the thing about technology is that technology is less about the how novel a concept is, but really about its adoption. And I think a lot of adoption really is about change management and understanding that the workflow that's gotten us this far is not necessarily going to be the workflow that's going to continue to progress us forward. I think EHRs were a great advent to the clinical world in terms of cataloging data, making things legible, et cetera. I think one of the challenges is that medical providers were used to documenting everything with pen and paper and in soap note format. And now all of a sudden there's this new non-personal way of documenting that a new medical provider needs to learn while they're in practice and have been in practice for some time. I think that newer generations of clinicians are doing much better at having that incorporated into their day to day. There are some clinical decision support tools that exist out there. I think some of the biggest challenges are alert fatigue and solving for that, right? Making sure that you're not getting all these pop-ups that are really not insightful and really not timely. But so heading towards clinical decision support is really where we're going. There are some things that can help guide test selection based on a group of symptoms that may be used in, for example, an emergency room setting. But I think now the best way is to really, use data in retrospect and to see what that means from a prospective standpoint. And so what typically will happen is provider organization or payer organization would give us an ongoing cadence of data. For example, on a monthly basis, the last months in retrospect, even closer together, depending on the type of model that we're looking for and how quick the change is likely to be seen. And then we provide a cadence of inputs back along with a couple thresholds. One that can identify, hey, this person has really doubled their risk. And so this is a keep an eye on type of patient, as opposed to this is a person who's exceeded their risk. And now the likelihood of an event is really substantial. And so we need to intervene now. And so that's most of the ways that we provide these. Really, it's more in the workflow of a care manager. A payer would use them in a care management capacity. There are accountable care organizations or provider organizations that may want to just right size the risk of a population in retrospect and really provide those necessary nudges directly to their providers. That's the way it would be used in the most efficient and effective way right now. But yeah, we are evolving more towards real-time clinical decision support. Obviously, the barrier to entry there is that everybody has different workflows. Everybody has different EHRs, and really working with those individual organizations, their care managers, all the ancillary staff that sort of affect patient care in a provider's office, and really use them all to decide how those nudges ultimately are going to be used for a provider to drive care for a particular patient.
I think that's great. And again, I think your experience, right, as a physician and having lived this and breathed it is very important in including that in the process because I don't think that others necessarily have that experience. You had mentioned about Alzheimer's and dementia as being one of the ways in which you are able to differentiate for those patients and get them in the appropriate track of care, if you will. That's important for their health. Are there other examples that you can share? I love case studies. I'm sure our audience does too. And so would love to hear if there are other situations or areas that you've been able to help with.
Yeah. In terms of other models, so where we have one that predicts falls, so its accuracy of our falls risk model a year in advance has about a 0.85 area under the curve, which is pretty accurate. We have a model that can actually predict the trajectory of renal disease and renal failure. The Alzheimer's or cognitive decline model is not only really looking at the things that lead to cognitive impairment, but beyond that leads to be able to predict which type of cognitive impairment an individual has. Do they have Alzheimer's disease? Do they have Lewy body dementia? Do they have multi-infarct dementia or vascular dementia? Or do they have something like that's reversible and can be solved with medication or intervention? We have models that are devoted towards cardiovascular health and cardiovascular decline, chronic obstructive lung disease, and identifying who's at risk for that. We have some diabetic prediction models that really can predict kind of trajectories of diabetes, the impact of diabetes and organs. So it's really multi-system, again, mostly in the clinical space, but some of them are around, hey, what does it mean that someone has a gap between provider visits in terms of their likelihood of being admitted and their likelihood of being a longer length of stay in a hospital setting? what does that mean to their likelihood of being readmitted? Because we know that follow-up care is so important. And not only are we including in these models the medical data, the claims data, but we're also including social data as well. We know that the likelihood of readmission and the likelihood of some of this decline diminishes if person's more affluent and increases if they're not. We've actually incorporated into all of these models some cohort data that subdivide individuals based on geography, based on socioeconomic factors, et cetera, to understand whether or not those become features in risk selection for individuals as well.
I think that's fantastic. And you talked about technology and earlier had mentioned adoption. And I think about what's called the TAM2 and in essentially a complicated thing that gets broken down into two things. People need to see themselves as users and they have to determine that the technology that they're using is useful, right? So they have to see themselves as users of that iPhone and then they need to feel like their interaction with it is providing some value to their lives. Take me through the argument. We have B28, we have all of these changes in healthcare and all these new programs, and it's where do you look? Make the argument or the case for me as an organization, even as small as say an independent right physician, make the argument for me as to why I would want to invest in this or bring this into the work that I'm doing today versus other things that might be out there that I might be considering.
Yeah, I think in terms of, so obviously things that are created by clinicians that sort of straddle both the technological aspects as well as the clinical aspects, people that are able to talk but also walk the walk, I think that's obviously really important. It's not only myself, but a whole clinical team that's behind it, that's really driving the appropriate data pull, the appropriate data cleanup, and then the appropriate data utilization in to create these models. I think that if you do have the opportunity to use a predictive model that has been vetted clinically, has been vetted from an informatics standpoint, has been vetted from a data science standpoint, it's likely to cause improvements in workflows internally and really drive the not cost centric care, but value centric care, right? You're really providing the most meaningful interaction with a patient at the point of care delivery. And that's going to lead to a return on investment for a clinician who's not having to see a patient repeatedly or not having to utilize other areas of the healthcare ecosystem repeatedly because issues are being dealt with in a proactive way instead of a reactive way. And then I think at the end of the day, too, is one of the things in terms of, you mentioned vulnerability before, there's often situations where you've created enough of a human connection with a patient that it doesn't matter how they get better and what solutions are deployed to get them better or what colleagues you have to bring in to get them better. You just want to get them better. And I think that's why we all went to school and learned. We ultimately wanted to deliver compassionate, impactful, real-time care to individuals. And so there is that sort of altruistic aspect of it is the care that I think people expect to receive when they enter a provider's office. And it's really consumer centric in that regard. And it's not always consumer centric to say that the outcome is always good, right? But the outcome is always discussed. The outcome is makes sense. It's less about finding cure and more about relieving all of the suffering that kind of exists from a physical, mental, social standpoint. This really, I think, it's solutions like this that really start to decompress all aspects of that total person care and unpack that all in a way that's really personalized for an individual patient. And I think that's probably the most important thing. And it's interesting. I've been really interested in sort of the health technology, health informatics space for some time. A lot of us, we go to professional school. In my case, I went to medical school with the understanding that there's no way that I could ever drive, care improvement for individuals through the use of technology. And while I was immersed in the practice of medicine, it was more of a hobby, right? And less of part of the whole reason why I went to school. I found that in your 40 patient day, where you're sitting on fires, right? And you're not able to do things at scale. I think this is a way to create a micro scale in every provider's office so that they could see qualitative and quantitative benefit for all their patients, not just individual patients on a one-off basis.
Great points all the way around. I love the analogy about spitting on fires. Speaking to some friends of mine who are also physicians, that's always been part of the conversation is that They went to medical school for a particular reason. And then when they came out, they found that they were doing other things. And I think that there's been some impact to morale. And then also to even some of the things that we see around physician burnout, and when the resulting physician shortage. And we're talking about providing more care and how can you do that as the folks that you need, right, to provide that care or are leaving the system in droves to some extent. So, really
Yeah.
important points. Uh, is there anything else that you want to tell us about what you're doing over at Discern Health that would help whichever stakeholder? And if we haven't talked about, I know we've talked a lot about physicians and health plans a little bit, patients, but maybe even identified the stakeholder that you would want to share.
Yeah, I think those are the major ones. Addressing that issue of the provider burnout, provider disengagement. Yeah, we've had years where, for every one new provider that joins, three leave. And I think it's really this supply demand mismatch is becoming a real phenomenon. We're at a point where patients are not only aging, but they're aging in ways that are more complex and more personalized. That personal, socially appropriate way, psychologically appropriate way, medically appropriate way of delivering care has become really complex and nuanced. And I think that there are going to be alternative care delivery methods that are going to need to exist as we evolve as a medical community, be it hospitals at home or who else is part of that care team. We've seen that evolve just during the course of my career. We've seen situations like the COVID pandemic really stretch us and really, I think, challenge the morale and the resolve of providers, largely because of the fact that there was so much information thrown in multiple different directions at providers to make those decisions. And so I think that there are going to need to be these solutions. And I think that there's already some government initiatives that are around making sure that there's data transparency, making sure that there's explainability of data that comes from predictive models and AI. All of these things are important things to put in place now as the need for these technologies continues to evolve. And so some of our opportunities really do exist in the state and federal areas. They do exist in how we personalize targeted medications for individuals and evolving into pharma, et cetera. There's even advocacy organizations, patient advocacy organizations that are looking for solutions to connect the patients who really don't know where to turn and really need that care navigation. And so we've started to work with some of them really to provide that care navigation. We often think of health literacy and conflate it with literacy. There's a lot of very literate, educated people that do not know how to consume healthcare in this country. And we're eliminating the key piece of the equation in the patient. And I think that this is a way to provide all of the other members of the ecosystem with the necessary tool to make that care navigation on the part of the patient a little bit easier.
Yeah, I only raise my hand because working in healthcare have been in those experiences myself, and I am grateful for the experience that I had. But I often wonder, I'm lucky, right? But I think that there are lots and lots of other people that maybe they don't have that experience. And so it becomes very challenging and very difficult.
Absolutely.
Yeah. I love the name Discern Health, and already in my mind, I'm thinking why you chose that name, but would love to hear you opine just why you thought that was the name for your company.
Yeah, we actually, when I joined a little less than 6 months ago, we were called Meridian Analytics. I thought that Meridian Analytics really didn't explain what we were or what we were angling at. The whole notion of Meridian was really this idea of creating sort of a longitudinal view of a patient's care journey, a patient's trajectory. But I think it's less around that longitudinality in retrospect and more about forward looking. I think discernment is that sage forward looking that really is about information gathering, having that, I don't want to say clairvoyance and make it too mystique or mysterious, but it's really about being able to look into the future and really predict and make impactful decisions that were thoughtful in multiple different facets of that patient care. And even the details around our logo, for example, the eye in particular has an eye, a dot at the eye of the eye looks almost like it's a nod to the eye, that forward facing eye. The eye itself looks like a person in the way it's put together. And it's really, again, that person centric, very visionary view of a person's trajectory as they move forward. And so I think it was an agreed upon. We iterated on a couple of different names. This was the one that was simple enough, telling enough, and could be explained enough about who we are and what we do and its impact. And that's why we settled on Discern.
And I just thinking if I had to sum up our conversation today, I really think about, again, there's this wealth of data out there. We recognize that there are so many aspects that go into the overall health of a person. And so if we really want to be successful on different levels as far as improving health outcomes and making healthcare better, getting at that quintuple aim, it's able to sift through that data, identify what's important and bring it right at that critical time when it would be most needed in order to make a change. And so it sounds like a perfect name to me and a perfect way to think about how our industry is transforming and really looking towards the future of how we can bring tools like yours to bear. So, great.
Thank you very much. I think the quintuple aim is obviously very important. I think a lot of what our data evaluation looks at too is the absence of key pieces of data that sort of complete a picture and make sure that individuals are getting the necessary things to fill care gaps. There's even some organizations that are using us for kind of HEDIS numerator and denominator impact. So there's a lot of different care pathways, payer pathways, et cetera, that really could benefit from what we're doing. But yeah, it's
I was going to
a
say,
growing team.
talk about that a little bit because I think as someone who does research and I do a lot in qualitative research, one of the things that I always attend to are the silences, right? And that sometimes people think, oh, the absence of sound is not really significant because you're not saying anything, but I think you absolutely are. And so this idea of silences and data, I think it's so important. Talk a little bit about what that means for you and why that would be important for us to pay attention to.
Yeah, I think just even as a provider, I've been fortunate to provide care in a bunch of different care settings, in poor resident run clinics in urban environments to suburban, probably the most affluent environments. I've done volunteer work around the world, some of it in really medically watershed areas. And the complexities of patients that exist, for example, when I've spent some time in Haiti, or there's so many different things that influence their ability to get care. And that's obviously an extreme example, right? Because there's social factors there that are huge, financial factors there that are huge, access issues, et cetera. Yeah, you look at medical care documentation, it's probably equally poor. And so there's insights that you can derive from the absence of data about gaps that exist in care. The other thing is that I feel like when you're in more vulnerable neighborhoods, there's there's less that a given provider knows because of the time constraints. There's less that they know because of the lack of continuity. And so that absence of data is really important in those geographies to really identify perhaps we're undervaluing the impact. And so we need to look at other social factors to create not fudge factors, but qualifiers to the way this data is evaluated. And we see this time and time again. Look at how the genetics world has evolved and cancer genetics. We know a lot about cancer genetics for populations that tend to enroll in research studies. There are populations that tend not to enroll in research studies, and they tend to be more marginalized when it comes to the ability to access some of these solutions from a care delivery standpoint. I think not getting those signals doesn't mean that they don't exist. It means that they probably exist and may even be amplified. They just need to be, we need to understand that in certain populations, we have to pay attention to the silence. I think one of the things that we do is as we deploy models, we understand that there are geographic factors, there's cohort issues. A model that's deployed for a payer in Louisiana may be different than the outcomes or the relative weights of a model in an affluent area in California or New York, right? The features that sort of drive identification of a risk may be more muted or more pronounced in certain geographies. And we take that into consideration as well. So again, that's really creating the weight based on the absence of data for other things that may actually be strong signals for care.
I love that you brought up the volunteer work and then also Cheetah talked about the differentiation in geographies that potentially exists or does exist. I'm curious to know if there's been anything that you have either learned in the United States healthcare system versus where you volunteered. And I'm assuming, and you had mentioned Haiti, but I'm assuming that you participated in other countries as well around the world, where either what you've done in the United States is influenced there and then vice versa, right? Are there learnings that you've picked up there that have factored into the work that you're doing today at Discern?
Yeah, I think factored into just my overarching concept of care delivery. The sick role is very different from place
Yeah.
to place, from geography to geography. We know that culture has a lot to do with it. We know that affluence has a lot to do with it, and so that definitely is something that is very important. What works in one area doesn't necessarily work in all. I would love to be able to find out that we can identify with 100% accuracy all of those individuals that are going to fall. But if there's no solution to bubble wrap people in certain geographies, then it doesn't matter that we can predict it if we can't actually action on it. Understanding, I think, the medical care delivery in an area is really important. I think as Americans, we tend to go out and our initial default is let's be imperialistic about the way we deliver care or the way we do anything to help another area that may be disenfranchised in the world. And sometimes having US tools that you use somewhere else doesn't work. Sometimes having Louisiana tools that you would deploy in, New York that doesn't work, right? And so you really have to be contextual, and you really have to. It's really got to be care specific. And I think as we think about the whole notion of personalized medicine, it's really incorporating these aspects of care delivery. Really being aware of. And I think what's one of the things that I've learned that's frightening is that we often indict other healthcare delivery systems because of the fact that there's wait times or because of the fact that you can't get specialized treatment. I feel like we do a great job of delivering care, and we spend a lot of time on the last mile of care. There's nowhere else to get the best, most up to the minute cancer treatment for a late stage malignancy. But we lack so much when it comes to preventive care. And really, nutrition doesn't have as central a role. Exercise doesn't have as central a role. The whole notion of community and public health was challenged and tried during the COVID pandemic and has not been as central as it's been in some of these other geographies. And I think one of the most staggering statistics is having spent time in Haiti, many metrics of healthcare delivery are as good or as bad as some places that I practiced in the United States. And I could tell you, I trained in a zip code where the life expectancy of a patient in that zip code was probably very similar to life expectancy of the country of Haiti.
Wow.
It has to do with many different social factors: access, food deserts, the inability to go out and exercise the way you'd want to go out, violence, drugs, HIV. There were a whole host of things that really made it so that infrastructurally it looks very differently than it does in Haiti. But at the end, and this is what it's all about, the result ends up being the same, right? So making sure that as we embrace technology, that we embrace technology in a way that's accessible for all, because we do have the foundation of the best healthcare system in the world. The barriers to entry are the access to timely data, the access of all people to all different types of care pathways, care navigation. And that's, I think, what I've been trying to solve over the course of the last 5 years of my career.
I love that. Great points. Great. Anything else that you want to talk about?
I think just hats off to my team. I obviously have very smart people that understand math better than I do and understand model building better than I do and can code in Python better than I do. But I'm also blessed to have a clinical team, a growing clinical informatics team that really is really expanding the thoughtful, responsible use of data to really drive care outcomes and really improve lives and health spans of people. And I think we go to work at the end of the day because of the fact that there's an overarching mission that we're solving for. I think it's about why. And I think that this is, be it my personal life with my wife and children and their healthcare, or be it some of the volunteer experiences that I've had, I think you begin to create a framework of why you exist, right? What you do. And I think that I've surrounded myself where they've surrounded themselves with me. And I think we're growing a really great team that's all very laser focused on what we need to do to improve patient care.
I love it. Absolutely love it. And absolutely agree with you and finding what is that thing that drives you and what's the larger purpose of the work that we're doing. And even going back to some of the earlier conversation that we had, if you can align around that, everything else falls into place. So want to thank you so much for giving your time today. And if folks want to contact you, they'll be able to get the information in the post. And hope that we get to have you back and have further discussions and learn about how things are going. Thank you.
We'd love to. Thank you very much. Appreciate it.